Hello, everyone. My name is Alexander Nam, and I'm a law clerk here at Lowes Parker. Welcome to today's webinar, hosted by the Texas Association for Home Care and Hospice. Today's webinar is entitled Building from Baseline, Practical Advice for Strengthening Your In-House Home Healthcare or Hospice Compliance Program. Today's presenters are Heidi Kocher and Richard Pecore. Richard Pecore is a 30-year attorney and senior counsel with Lowes Parker, who has been with the firm for the past 12 years. He focuses mainly on administrative appeals, regulatory healthcare compliance matters, billing contracts, and compliance programs for our clients. Prior to joining the firm, Mr. Pecore worked on improving workplace safety, compliance, and heavily industry in the oil field, as well as on personal injury cases involving asbestos and silica lung injuries. His office is located in Houston, Texas. Our other presenter is Heidi Kocher. Heidi is a partner with the law firm of Lowes Parker. She has over 20 years of experience advising and defending healthcare clients on legal and regulatory matters affecting providers of all sizes. She is an expert in all aspects of compliance and privacy programs, including developing and deploying policies, procedures, and training. Her experience includes serving as Chief Compliance Officer and a Chief Privacy Officer, implementing the various requirements and aspects of corporate integrity agreements, and responding to and defending audits from Medicare, Medicaid, and private insurers, all through the ALJ levels. She received her JD from Georgetown University Law Center, and she is licensed in Texas and Maryland, and admitted to the U.S. Court of Federal Claims. She is certified in healthcare compliance as well. Just a quick reminder, if you have any questions throughout the presentation, please feel free to type them in the chat box, and we will address as many as we can at the end of the presentation. Without further ado, I present your speakers, Heidi Kocher and Richard Pecore.
Howdy, folks. My name's Richard Pecore. Heidi is with me. Say hi, Heidi.
Hi, Heidi.
We're very lucky to have Heidi with us today. Heidi has been doing this stuff a long time. She's seen a lot, done a lot, and she may regale us with a story or two as we get through these examples and issues. And without further ado, let's get rolling. First slide, please. Next slide. One more. This presentation is general information only, and just the usual disclaimers that for educational purposes, if you have a specific legal situation, you want to contact an attorney and talk about your specific facts and specific situation. As an overview, we're going to look at first steps and say, okay, I've got an audit or someone has walked in with a badge. What do I do? The next section is your first line of defense, which is going to be your compliance plan and your contract. Then we're going to talk about the different types of situations you can get in: prepayment reviews, additional document requests, post-payment audits, and payment suspensions. Then we're going to talk about the criminal side with subpoenas, search warrants, investigations, and the fallout therefrom. Talk about exclusion of individuals, which is an area that I'm hoping Heidi is going to expand on a little, because that's a very important area. Stark and anti-kickback statute. This is something everybody needs to be familiar with. Self-disclosure protocols, HIPAA, patient abuse or neglect, and our final recommendations on how to help resolve the problem. Next slide, please. First steps. What I do: don't panic. Take a breath. Know that who or what you're dealing with. You're perfectly fine asking for ID if it's on site. They're required to show it to you. If they have documentation, get a copy of it. They should be presenting it to you, but if they don't, ask for it. See what's being requested. What are they taking? Are they with the government? Are they a contractor? Are they private? If it's a government matter or a civil matter, you're going to get an indication from the document that you're being presented with. The second situation is stop the bleeding. You need to contact your attorney now if you haven't yet done so. Whatever you're doing at the moment, just stop. just take a breath. Gather whatever necessary documents they're looking for. And this is the most important part. And Heidi, you can back me on this. How many times have we seen a situation where the folks have documents taken or turn them over and they have no idea what they've given them?
All the time.
It happens way too much. Make an exact copy of everything you've pulled for your attorney. We need to know what they have so we know what they don't have if there's anything we need to supplement. Check with your insurance carrier. And above all, do not ignore the problem. This is not going to go away. Next slide, please. So what's your first line of defense? We're going to talk about your compliance plan and your contract, but first we're going to talk about the compliance plan. Everybody should have one at this point. It's been on the books for way too long, the law has, and everybody should know this. So there are 7 elements. It's posted in the Federal Register: the written standards of conduct, policies, and procedures, designation of your compliance officer and committee, conducting effective education and training, developing effective lines of communication. This includes process such as a hotline to receive and field complaints. And then you're going to be enforcing the standards through well-publicized disciplinary guidelines. What does that mean? Your employees know what they are. Conducting internal monitoring and auditing, and boy, Heidi, how many times have you seen this neglected?
Oh, more than there are fingers and toes.
Yeah. The thing is, there's so much that your auditing procedure and your monitoring procedure can catch. People are human. They fall into bad habits. You need to ride herd on it. And this is where your compliance plan comes in. Responding promptly to detected offenses and developing corrective actions, including tracking and implementation. These are the things that you need to be using the compliance plan for. It's not just a book on a shelf to be sitting there. You need to apply it, and your compliance officer is the person that's going to be in charge of that. Next slide, please. One thing else I want to say about your compliance plan is these days, it's your best tool to anticipate audits and try to get ahead of the curve. Heidi, you can back me on this. The success rate on appeal has fallen drastically from when we started, when I was looking at this even 10 years ago. It's just not where it was. So if you want to avoid this and have success on appeal, you need to have your paper in the best possible shape it can be in. And it all depends on documentation. Every overpayment appeal, every investigation, it comes down to how well you document. When you look at the OIG model program compliance for home health agencies and hospices, this was published in 1998. There's the link if you want to take a look. It talks about the various risk factors for home health agencies. And this is something you need to be aware of because you're required to do a risk analysis. So these are a lot of areas you can take a look at. And we're going to talk about some of the top areas of denial in the course of this. So you've got financial incentives to referral of sources for physicians, hospitals, patients. They could violate the AKS, Stark laws, federal, state laws. Usually there are state mirror laws in combination with this. So it's not going to be just one violation. The self-referral law usually also has mirror statutes on the state level, so you got federal and state effect. Joint ventures, where one party refers business to another, is an area. Insufficient documentation of what services were performed. Just insufficient documentation in general, but medical necessity is the #1 area of denial. Everyone probably knows that because why? It's subjective. It's nebulous. Usually now when you get a denial, the overpayment response to the spreadsheet, it doesn't even say medical necessity half the time. It says MN. That's how vague they can be about what they think is wrong or missing. So the better you can pay for the file, the better you can document what's going on, just the better overall. And the other half of that missing documentation are clone notes. And I want to mention it here because clone notes are such a problem. It's the next top reason for denial. You can copy information from the previous visit, especially if it's a patient that their condition hasn't changed much, but you must include new, different information as to what's happening with that patient now. There's nothing wrong with tracking where the patient has been up to now, but that doesn't describe what happens today. So you can't just clone the note copy for copy and expect that to pass, and you will get nailed for that. Insufficient documentation and or billing for patients that are not homebound. Items and services not actually rendered, medically unnecessary services, visits to patients who do not require a qualifying service, billing for knowing inadequate or substandard care, billing unallowable costs for home health coordination, duplicate billing. These are all things you've seen before. Next slide, please. False cost reports, credit balances, failure to refund, overutilization, underutilization of services, billing for services provided by unqualified or unlicensed clinical personnel. Boy, I sure hope you don't have that situation. That's almost as bad as the exclusion situation, but not quite. False dating of amendments to nursing notes. Everybody should know how to amend a note if they need to. You don't change the original ever. Okay, you take the original, you make a copy. You will, now this is if it's physical, you're going to attach a new copy with the changes and date and sign it. Usually when you're talking about electronic records, what it's going to do is going to put a line and strike through the old entry. You're going to make whatever changes, but you're still going to sign and date it. What you're doing is you're documenting the previous information that was an error and the date that it was made and who made it. None of that changes. You're updating it and you're adding to it, but you're also writing down who made that change and when. Let's see, falsified plans of care, false dating of amendments to nursing notes. We talked about that in timely, and forged physician certifications on plan of care, forged beneficiary signatures on visit slips, logs that verify services were performed, improper patient solicitation activities, and high pressure marketing of uncovered or unnecessary services, inadequate management and oversight of subcontracted services, which results in improper billing, discriminatory admission and discharge of patients, or patient dumping. Next slide, please. You'll pardon me, my mouth is a little dry. Excuse me. So sorry. Goodness. Billing for unallowable costs associated with the acquisition and sale of home health agencies, compensation programs that offer incentives for numbers of visits. I apologize. Performed and revenue generated. Knowing misuse of provider certification numbers, which results in improper billing, duplication of services provided by assisted living facilities, hospitals, clinics, physicians, and other home health agencies, knowing or reckless disregard of willing and able caregivers when providing home health services, failure to adhere to home health agency licensing requirements and Medicare conditions of participation, failure to return known overpayments made by federal healthcare programs, and that's within the 60-day time frame of discovery. The home health agency's prior history of noncompliance may require unique policies to address vulnerabilities and prevent recurrence. Next slide, please. And on the final slide here for this topic, improper referrals by hospitals that own home health agencies or hospices, patient abandonment in violation of law and federal health care requirements, failure to maintain HIPAA confidentiality of information and records, knowing misuse of provider ID numbers for billing, duplicate billing in an attempt to get duplicate payment, billing for discharge in lieu of transfer, failure to properly use modifiers, routine waiver co-payments, discounts, and professional courtesy. I got to get my teeth fixed on that one. Internal coding practices, assumption coding, alteration of the documentation, billing for services provided by unqualified or unlicensed clinical personnel, and employment of sanctioned individuals. Next slide, please. So what are some of the risk factors for hospices? And the Federal Register guidelines are listed in the link above. You can take a look at it there. And we're going to be rolling through these again. Uninformed consent to elect the Medicare hospice benefit, admitting patients to hospice care who are not terminally ill. Arrangement with other providers, with another provider, the hospice knows, and submitting claims for services already covered by the Medicare hospice benefit. Underutilization services, falsified medical records or plans of care, untimely or forged physician certifications on the plans of care. You see some of these are repetitive. You see the same things in hospice or home health environment. Inadequate or incomplete services rendered by the interdisciplinary group. Insufficient oversight of patients, in particular those patients receiving more than 6 consecutive months of hospice care. Next slide, please. Hospice incentives to referral sources. Now that's going to mean physicians, nursing homes, hospitals, patients, etc. They could violate the anti-kickback statute or other federal or state laws or CMS rules, including improper arrangements with nursing homes. Overlap in the services that a nursing home provides, that results in insufficient care provided by hospice to a nursing home resident. Improper relinquishment of core services and professional management responsibilities to nursing homes, volunteers, and privately paid professionals providing hospice service in a nursing home before a written agreement has been finalized if required. Billing for a higher level of care than was necessary. Knowingly billing for inadequate or substandard care. Pressure on a patient to revoke Medicare hospice benefit when the patient is still eligible for and desires care, but the care has become too expensive for the hospice to deliver. Next slide, please. Billing for hospice care provided by unqualified or unlicensed clinical personnel. False dating of amendments to medical records. High pressure marketing of hospice care to ineligible beneficiaries. Improper patient solicitation activities such as patient charting. Inadequate management and oversight of subcontracted services, which results in improper billing. Sales commissions based on length of stay in the hospice. Deficient coordination of volunteers, and improper indication of the location where hospice services were delivered. Next slide, please. So
before we move on, let me just add something here. If you all noticed the dates when these compliance program guidances were published, it was 1998 and 1999. folks, that's well over 20 years ago, and the government really expects you to have controls in place for these risk factors. And if you don't, this is where things really go off the rails. So you may think that these are boring risk factors, but they really are pretty important, and the government actually really looks to these factors when they do investigations.
Thank you, Heidi. That's very important, and you're absolutely right. So let's look at the next aspect of it. What is a payable claim? How do you get ahead of the curve? We're going to start looking at the things you can do. The 8 elements of a payable claim. Our fearless leader, Robert Lyles, spent time in the federal government mill working with the Clinton administration, actually helped head up the first OIG fraud task unit. And he came up with this information. He's also a former hospital administrator, so he's got a pretty good idea what he's talking about. And you can access this list at that link above. And the first, I mean, a lot of this is obvious, but it needs to be stated. You got to go through the checklist. Element 1, the medical service or supplies provided were medically necessary. That seems like a ridiculous thing to say, but you know, it's common sense. Can you justify it? Second item, the medical services and supplies.
I'm sorry, I'm going to jump in here as well again. And the definition of medical necessity may not be what you think it is. Medical necessity may be what is in the LCDs or the coverage policy documents. You may think it is medically necessary, quote unquote, from a physician's standpoint. The physician says, I think this is necessary, but that doesn't mean it is medically necessary from the point of view of the payers. So remember that medical necessity may mean you need to look at your insurance coverage documents to see what they define as medically necessary.
That's an important point. Thank you, Heidi, because you reminded me of something else. How many times have we seen folks that they never read their private payer contracts, so they don't know what's in it. They don't know the appeal process. They don't know sometimes some of the items that are in the provider manuals. It pays to read this stuff.
Very true. And what people don't realize is that your private payer contracts usually have compliance program requirements in them as well. They're buried somewhere in the back, but you need to be aware that while they often parallel or mirror the federal compliance requirements, they're not always identical.
And there's one more aspect to it. There's a lot of these private payers and their SIU units, their special investigative units, that now make referrals to state AGs if they run into a problem or potential fraud. And sometimes it's automatic, so you need to be aware of that. Again, we're back to documentation. You know, it all comes down to how good is your paper. That comes down to the same element when you're trying to get your lawyer to help you. We can only defend the paper that's there. We can't defend what's not there. So again, that's going to help you win your claims. And when you're talking about an overpayment, the paper is what we work off of. And if you have good paper, we can help you win a lot of the claims. If you don't have good paper, it's not going to help. You want to make sure the services and supplies were actually provided. Number 3, no other statutory violations were committed in connection with the medical services or supplies provided. What does that mean? Well, for instance, if there's a potential anti-kickback statute violation, let's hope there's not also a start violation from a self-referral that cropped up. But you're basically being careful that the services you ordered were medically necessary in accordance with the rules or your contracts, and that they were actually provided and that they were properly documented. And when you're doing that, you should be pretty good as far as staying in line. Number 4, all applicable eligibility and coverage requirements are met. That's sort of a precursor before you get into this. Number 5, the medical services and supplies provided were properly and fully documented. Gee, where have we seen this before? It could be why it's in red. Number 6, medical services or supplies were properly coded, properly billed, and then they'll be properly paid. You have anything else to add, Heidi?
Just remember that element number 8, were properly paid, also includes an element that Richard mentioned earlier, which is if you were paid improperly, you are expected to have returned promptly, i.e. within 60 days, any overpayments. That is also lumped into the properly paid aspect.
And what's important about that is it's 60 days from the time it's discovered, which is why you want to contact your attorney to see when you find an overpayment, because you need to find out how deep does this go? How many are we talking about? How big is the elephant? Because you don't want to start with the return of a single item and you discover there's a whole string of them because this has been going on for 8 months. Next slide, please. So let's talk about the billing contract, because that's your next protective step. Billing contract should address many of the issues by delineating party rights, obligations, remedies. The reason you have a contract is to avoid conflict, to stay out of court, and to resolve differences and peacefully part ways if you can't stay in agreement. It's also the way you get paid, so it's kind of important. Examples of provisions that should be in your client contract are going to include a termination provision. This is going to help specify when the contract or responsibilities can be terminated either immediately or at will, or where the provider is subjected to an adverse action that impairs the ability of the billing company to be paid promptly in its efforts, such as prepayment review, payment holds by payers, or suspension. What happens in that situation is that most billers have in their termination clause, if you get put on prepayment review or post-payment review and your money is suspended and it's going into escrow, they're not getting paid. They can't afford to work for free. Most of the billers are too small to do that. They couldn't survive. So they have an exit clause in the termination. And that's something you should be aware of. If that situation occurs, you could lose your biller. So you need to start making alternate plans. Handling of requests for refunds from payers. Responsibility for credentialing. Information and documentation to be provided by the provider. The responsibility for coding. Who's going to be doing it? Is it you or the biller? HIPAA compliance and the establishment of coordination for compliance efforts. That's really important because if they discover a problem or a compliance problem that needs to be addressed either in the billing or the processing or something that's going on, you need to be able to take action and you need to be cooperating with your biller. So if they tell you about something, don't ignore it. Insurance responsibilities include, among others, E&O insurance. That's pretty standard these days, but cybersecurity insurance, legal insurance, other types of insurance, if you can afford it. Those are great ideas. Heidi, have you run across any situations where you had a client that didn't know they had legal defense insurance, and then all of a sudden, hey, I can get some of this paid for?
Yes, I've actually had that situation. I think most people understand the E&O insurance pretty well, but what you need to do is you really need to understand what the terms are of your insurance. because different policies have different triggers for when coverage applies and different exclusions. So you really need to understand not just your insurance, well, your insurance mainly.
Seems like you're saying read the contract. I think we've said that before, right?
I am definitely saying read the contract. And again, those kinds of things like the triggers are not on, a lot of people look at just the declarations page, the one pager, but these important provisions are not on the declarations page. They are, again, buried in the rest of the contract, the rest of the policy.
Yeah. I can tell you a horror story along that line. If you, for the folks that are involved with billing in Texas, you don't want to do any percentage-based billing in Medicaid, and that makes things problematic. But the actual place where it prohibits it, it used to be a simple one-sentence, black and white statement, but it was still buried on like page 42 of a 75-page provider application. And it was a single sentence. It wasn't in the statutes. It wasn't in the regulations. It wasn't in the Medicaid rules. It's in the contract. So these are things you have to be aware of. And believe me, we know whereof we speak. Next slide, please.
And as while Richard is pulling up this slide, let me just also say, although this applies to if you have a billing company and a billing contract, these principles actually apply if you do your billing in-house as well. You need to be thinking through some of these aspects, you know, like who's responsible for what, and you know, who's responsible for credentialing, and what information are you gathering, and who's going to turn it over. So if those of you who are doing billing in-house are on this call, don't ignore these slides, because many of these thoughts and recommendations that Richard is saying actually apply to you as well.
And that's important because it kind of harkens back to one of the first things we were talking about when we were saying, you know, get ID, and you want to cooperate with these folks when they come in and audit. You don't want to get into a fight with them. You don't want to get into a confrontation. But there's something else. You want, you know, making a copy of all the documentation and everything else that's involved, but you want to stay in your own wheelhouse. Your employees, when folks like that come in, especially if they have badges and guns, they get nervous. They want to volunteer information that may not be in their area, that they really don't have any knowledge about personally. They just heard around the water cooler or the coffee pot. This is not what you want to be doing. You know, you want to instruct your folks during your employee training that if that comes in and it's a question that pertains strictly to their area, you do want to cooperate. You want to answer truthfully. But if it's outside your area and you know it's outside your area, say, you need to talk to this person about that. That's outside my job description. I don't do that. Any other horror stories, Heidi?
I'll save them for later.
Okay. As examples of provisions that should be in the contract continued, we're going to talk about the right of the billing company to conduct periodic on-site visits with the provider. Why on earth is that in there? Well, if there's a problem that they've discovered and it's in the processing part and we're seeing a consistent issue coming up, it could be in the training, it could be in the way that they're submitting the documentation. They're usually, at least in our contracts, we have in there the right to conduct a sample audit if you're the biller, because the best way to do that is pull some stuff fresh off the line and see, you know, what's going on here. The responsibility for maintaining secure communications via direct fax number and HIPAA compliant secure email. The point is that your communications need to be secure. And you're also going to establish a business associate agreement for if you're the billing company or this is within the billing department. you still need it. No responsibility to bill claims for insufficient or ambiguous support. That's, in other words, if you're the biller, from the biller's point of view, if they don't get cooperation from the provider, then they're probably going to terminate the contract. If you're the provider, you have an obligation to provide your biller with correctly billed and coded documentation, and that's going to include everything needed to support the claim, i.e. medical necessity. So that's what your duty and obligation is in the process. Indemnification clauses, I've always kind of been of the opinion that you could take them or leave them. If I'm on the provider side, I don't like them. If I'm on the biller side, I do like them, because if you want to sign up for it, you're more likely to incur that obligation than I am. But frankly, I consider it a negotiating tool from the biller's point of view. If they can get that in their agreement, fine. If not, I don't think there's really any loss there if you say, that's okay, we don't have to do that. It's better than both of you agreeing to indemnification, in my opinion, because I never see the advantage in taking on someone else's responsibilities. If they're involved in a joint fraud situation or something like that, the government's going to drag them in anyway. So, you know, if you have to go back in a civil situation for contribution, then you're still going to be going back from that perspective, and probably the money that you're talking about is not going to be sufficient to cover what might be listed in an indemnification clause. So overall, I haven't found them to be too effective. Heidi, you may have a different experience in that.
You have to go to court to enforce them usually, so.
Yeah, so I don't think it's a whole lot of information lost there if you decide to waive it as part of the negotiation.
Mm-hmm.
Compliance addendum, this usually provides, what we do in ours, it has kind of a list of rights on it. It provides for such activities as review of the party's compliance program on request. You know, if I keep running into problems from the biller's point of view and I want to help you as my client and say, well, let me take a look at your compliance program. I'm pretty familiar with these. I have a lot of clients. Maybe I can spot a couple of holes and see something that might help you. Just another pair of eyes. Periodic conferences to discuss compliance. It sort of helps keep you and your biller on the same page. And it has a chance for you to pull your biller in too and ask them questions. Responsibility to conduct complete background checks to ensure that services are provided by individuals who have not been excluded by any government authority. And that is a responsibility you can't delegate. You can contract it, but you can't delegate it to your biller or somewhere else like that. Most of them won't touch that responsibility. And remember that whoever you hire, ultimately, you as the provider are responsible. So it's on you. And if I'm the one responsible for that, then I'm going to either be checking it myself or hiring a service that's going to give me detailed reports. Let's see. We want the right of the billing company to suspend submission of any and all claims where the billing company reasonably believes there may have been compliance problems that would subject either party to compliance violations. If there's a potential fraud violation or an overpayment, and you as the provider said, I'm not going to pay any attention to that, I'm not going to return it, or we're just going to keep doing it the way we've always been doing it. How many times have we all heard one of those? Well, if I'm the biller, I am going to exit stage right just as soon as possible. And I've run into a client actually that I had to fire because they told me to my face that they're going to keep doing it the wrong way. I told them you can't do that. They said, well, it's the way we've always done it. Well, that's a lousy, justification when someone who is educated in the law just told you that you're violating the law. So don't do it. That's all I can say. Heidi, help me out here. There's got to be something you want to say on that topic.
I think your comment about we've had to fire people because they've insisted on doing it wrong pretty much covers the waterfront there.
You could not just lose your bill, you could lose your legal representation. If you're determined to do it wrong, or there's a doctor that's just so hard-headed or thinks he knows everything, I can promise you that's not the case. I've met doctors that are terrific medical people, but they are horrible business people. I've seen it time and again. Doesn't mean everybody is, but it happens. So next slide, please. I think this is my last slide, and I think Heidi's going to jump in here in just a minute. So billing agreements, when we're talking about federal limits, usually Medicaid pays a provider, except for the exception situation of reassignments. That's 42 CFR 44710F, which I am very well familiar with, where the Medicaid pays the biller directly, and in that situation, percentage-based agreements are prohibited. Okay, let's talk about percentage-based agreements for just a second, because it's the favorite amongst both providers and billers. Why? It is the most efficient. It gives you the best bang for the buck. It gives the biller or the billing department the best return on their effort. The harder they work, the more they get paid. However, a lot of states have a lot of problems with it. So there are restrictions. And from that perspective, the easiest way to describe it is California is pretty much anything goes, and New York is nothing. Now, surprisingly, just about any other billing method is fine with everybody. The Fed, the states. If you want to bill flat rate, if you want to bill hourly, if you want to bill volume-based, everybody's okay with that. It's just percentage-based, and that's because they're all rooted in fee-splitting prohibitions, because they were worried about the patient being properly cared for and money getting in the way. So when you're talking about state laws, you're talking about 50 states, so you got 50 different sets of laws. You got DC, you've got territories like Puerto Rico. It's all a different set. So know the law before you jump in and sign on a percentage-based agreement. Make sure you're compliant with your state's laws. As I said, some states prohibit them entirely, like New York. Some only prohibit for Medicaid billings, like Florida and Texas. What happens there? That creates a bit of a dilemma for the billing department or for the biller. You can either try to sort your bills by Medicare and Medicaid, but that just increases the chance for error and doubles your work, or you can just choose a different billing method for everything. And that's usually what I recommend. Some states prohibit only specific professions or disciplines, like Pennsylvania. A lot of states do that. Dentists, chiropractors, podiatrists, some mental health professionals, behavioralists. These are the types of disciplines where you frequently see percentage-based agreements prohibited in a particular state. And there's no rhyme or reason to it. It could be, it's just whatever they're having problems with. And it varies from state to state. Most states, 34 out of the 50 that I'm aware of, use a combination of restrictions. So why does it matter? Because states will penalize the provider for signing any prohibited agreement. What does that mean? It could mean fines. It could mean civil monetary penalties. It could mean revocation. And in a couple of states like Maryland, it could even mean prison. just know that each state's laws are different. Your state law may permit it. It depends on just what the law says. It's worth researching. If you go out of state, or if you have more than one office out of state, or if you have a client, if you're a biller and you have a client out of state, or you're a provider and you have more than one office and you're in multiple states, just know that from the billing perspective, they're going to have to comply with both the states where the activity is taking place. If your biller is out of state, they're going to have to comply with the home state's laws and wherever your patients are, whatever office they're going to. So just another complication you need to be aware of. Heidi, I think I'm done with my section. You want to jump in and let her rip?
Sure, thank you. Next slide, please, Gio. All right, well, we're going to switch to another area of concerns, and this is prepayment reviews and ADRs first, and then we'll talk about post-payment audits and suspensions afterwards. So if you get a prepayment review or an ADR letter, they're always asking for additional information before they pay the claim. So this is really your best opportunity to make sure that your documentation is up to snuff, and you want to do this before you send it in. So we have the checklist of points here. You know, is it medically necessary? Again, remember my comment earlier about medically necessary may mean different things depending on what the insurance is that covers the patient. Documentation that the services were provided. Are there any statutory violations? Have the coverage requirements been met? Is it properly coded and billed? And can you anticipate and field the most frequently cited denial reasons? They periodically publish what the top denial reasons are. It's always a good idea to look at those and see if you can then look at your claims and say, oh, so let's see, home health, face-to-face visit is not properly documented. So you go and you look and make sure that all of your face-to-face visit documentation is proper. So those are some of the things that you want to. You want to review your billing contract. If you have a biller, there's some considerations here. Richard kind of hit on a lot of those as well already. Next slide, please. For post-payment audits, so this is often what is known as pay and chase on the payer side. This is where they have paid you, and for some reason they think you have been paid improperly. So in this circumstance, if you're using a billing company, your billing company is you're gonna need to use your billing company's help to pull and analyze and submit additional documentation. And again, just like with a prepayment review or an ADR letter, you want to review these claims and the documentation before you send it in. In other words, you are already under an audit by the government, so you should audit your own documentation before you send it in. One of the things with post-payment audits is that there are, of course, the appeals process. But the appeals process can take a very, very long time. And so it is not unlikely that any amounts that the payer says that you owe will be recouped. They can deny your claims or take payment for claims and apply it to the alleged overpayment. And so you need to figure out how you are going to survive that. For a provider, you know, it's pretty bad if your revenue isn't coming in and you still have all the expenses, and then you have to fight the appeals process as well. Think about also having E&O insurance. Again, as Richard said, you may have provisions in your contract or your policy where you can actually get coverage for help, particularly if you retain attorneys or outside experts to help you with that. So something to think about and make sure that you know what it is in your insurance. And again, if you find errors, don't be afraid to admit them and pay them back ASAP. You want to be on the jump. Again, post-payment audits often only pull a sample of claims. If you've pulled a sample, you want to look at all the other patients and claims that are similar, and again, see if any problems that you may have identified with the sampled claims apply in the rest of your universe of claims. You want to get a jump on this and be ahead of it. Next slide, please. Suspensions. This is a very tricky set of circumstances. So what happens is the payers, and Medicare in particular, can suspend a provider based on quote-unquote credible allegation of fraud. Let me tell you, having defended people who have been suspended for credible allegations of fraud, those sometimes can be relatively flimsy. So you want to see if you can get more information about what the suspension is. So you have to be, again, aware of what is going on. When you are suspended, you are usually suspended for 6 months at a minimum, and they can renew it for another 6 months, and they can renew it again and again and again. I actually had one client many years ago that was actually suspended from Medicare for 18 months before we managed to go through the appeals process and get them reinstated. Now, fortunately, they weren't solely dependent on Medicare for their revenues. They had private insurance contracts. But boy, it is not uncommon for providers to go under if they have been suspended. Now, you can continue to see and treat Medicare beneficiaries during a payment suspension, and you continue to bill for that. But what happens is you will not get any revenue. That goes into an escrow account, and that is held until the, again, audit or the issue is resolved. So the key question here is, again, can your company survive a suspension of payments? And here's the other thing. We have it mentioned in here from the biller perspective, but this applies to anybody that you're doing business with. So from a home health agency, if you contract out, let's say, your therapy services, this is going to apply as well. If anybody in your network is suspended for a credible allegation of fraud, then the government takes what I call the spider web approach, and they look out and see who else is affiliated or working with that suspended provider. And it will actually result, or it can result, in your suspension as well. So the example down here, the Rockwall, Texas doctor, those of you up here in the DFW area, this is the Dr. Jacques Roy situation. He engaged in fraud on referral basis, but as a result, 78 DFW area home health agencies were also suspended when he was suspended. And these were all based on the quote-unquote credible allegation of fraud, that because he had committed fraud, they were now painted with the same brush. So be aware of that as well. Next slide, please. All right. This is what always curls people's toes and makes people pucker: subpoenas, search warrants, and investigations. As Richard had said earlier, you are entitled to the documentation. Get a copy of the relevant document and provide that copy to your attorney ASAP. If it's a subpoena, you usually have some time to respond, and your attorney can work through the mechanics of how to respond and when to respond, and if there's any limitations on the response. Sometimes we can negotiate down providing less documentation, particularly if it is a tremendous number of pages or very burdensome to get. If it's a search warrant, there's not a whole lot that you can do about it. One of the key things here is do not get in the agent's ways. You don't necessarily need to help them find what they're looking for, but you cannot obstruct their execution of the search warrant. You want to make notes of exactly what they take. It is not uncommon for people to be subjected to a search warrant, and people are so flustered and so on that you have no idea what they took. And they may take, file cabinets, they may take, your computers, they may take iPads, laptops, whatever. You need to know what is on which laptop. Now, many people nowadays are on a cloud-based system, so that is better, right? We're not dependent on local servers and so on, so you can continue your business, but you do need to know exactly what they took, because this is going to be the basis of your defense. And then again, if they wheel away all your computers, do you have some kind of a business interruption contingency plan? Do you know how you're going to replace all of that equipment? And you might want to consider releasing a public statement that you want to review with your attorney. Public statements can be viewed as admissions against interest. So don't have your staff just answer questions willy-nilly. Do not give interviews. Have somebody designated in your agency who's going to be the point person to answer everything. And again, get that person an attorney for the home health or hospice agency, and make sure they understand what they're going to want to do. Big thing, there's an example here. We're a little short on time, so I won't go into this in detail, but do not lie to the FBI. That's a nice little thing you can remember because it rhymes. Do not lie to the FBI. If you are found to be lying, they are pretty they're not reticent. Let me put it this way. They will not reticent charging you with making a false statement. It's pretty easy to prove, and then you're facing 5 years in federal prison, potentially, and it is a felony that is going to follow you the rest of your life. If you are convicted of a felony, you are likely to be excluded, and you will never work in healthcare again. So don't do it. Next slide, please. Exclusion. Exclusion. This is a very important thing. The government has the ability to do what is called exclude individuals, and that means they cannot participate or receive payments that come from federal health care programs. And this applies to people like individuals, billers, and so on. They can't even provide administrative and management services, such as accounting or billing or even legal services, if their funding, if the payments for them come from a federal program. So very important. Many, many entities don't know about exclusion. I'm actually always shocked about how few don't know them. There are 3 primary ones that need to be checked monthly. There's the OIG's List of Excluded Individuals and Entities, LEIE, the GSA System for Award Management, or SAM, and then there's the Medicaid exclusion list for the state. Now, there are exclusion lists in multiple states, and if you have to check multiple states, I liken this to mowing the lawn. Can you mow your own lawn? Of course, you can mow your own lawn. Do you want to mow your own lawn is another question. In my case, I don't want to mow my own lawn. I don't like getting hot and sweaty, especially in summer. And so I have somebody mowing my lawn. And the same thing with exclusions, particularly if you have to be looking at multiple states. You really want to consider using a service, and we have resources for you in that. One thing to know in Texas, if you are taking Texas Medicaid, by regulation and law in Texas, if you are taking Medicaid, you have to be checking not just the OIG, the GSA, and the Texas state exclusion list, you have to be checking all the other states as well. So again, it makes it worthwhile to think about looking into a service. And remember that exclusions never expire. Even though the time period for your exclusion may have ended, you have to apply for removal from the lists and reinstatement into federal programs. So it's a big deal, and if you're a provider who has hired somebody who is excluded, You are likely to pay a fine to the OIG. I had a situation like that a couple of years ago. And the clinic, the family practice clinic, paid over $60,000 in fines and penalties for having hired an excluded person. So you want to be careful of that. Next slide, please. I'm going to skip this one in the interest of time. Next slide, please. Again, you can read this at your own leisure. Skip this one, please. Stark and anti-kickback statute. Okay, very important here. Just remember that Stark and anti-kickback do apply to your circumstances. There are multiple situations where a billing company or a marketing company or a therapy company have fallen afoul of the Stark and anti-kickback statutes. If you have any kinds of doubts about these, you really, really need to involve attorneys. And again, if you are doing business with another healthcare provider, you should be using an attorney and an experienced healthcare attorney to draft the contracts, because there are often many, many subtle little pitfalls. I call them snakes in the grass, right? They're the same color as the grass and they don't know they're there until you step on them and you get bitten. So you really want to be very cautious about violating the Stark and the anti-kickback statute. Next slide, please. Self-disclosure protocols. These are actually very important. So these are remedies that are available to providers, billers, and anybody else that you contract with, where you may have an issue that could subject you to possible civil monetary penalties or fines. And for example, here we have the use of an excluded person, kickbacks under the anti-kickback statute, or a self-referral in violation of the Stark. And each branch, so the Stark law goes to CMS, AKS goes to the OIG, and there are published protocols. And again, you really want to get with an attorney to get with these, because while the process may be relatively straightforward, there's a lot of potholes and implications. So for example, if you do a self-disclosure protocol, you are likely to have to sign a corporate integrity agreement. What does that mean for your business? What requirements will be imposed upon you during this interim period? And does it have any kind of effect on your licensure status? If you have to pay a penalty, in many states, paying a penalty or a fine to a government agency falls under the kitchen sink definition of any other conduct that is likely to harm the public. So you want to think through what you are self-disclosing and what the implication and fallout of that is. I am not saying don't self-disclose, but you really need to think through it and put in place provisions to limit the fallout from a self-disclosure. Just remember, self-disclosure is not available for the reporting of straightforward overpayments or errors. Again, those must be reported within 60 days of discovery. And finally, excuse me, many states have mirror statutes under the self-disclosure protocols, as well as under some of these other things. So we're always talking about the federal law, but you need to remember that the state laws may apply as well. Next slide, please. HIPAA, business associates. Make sure you know who your business associates are and that you have a business associate agreement in place. I am sometimes shocked by how many people do not have a business associate agreement in place. There's a case example here of a provider that was providing services and got hacked and ended up let me rephrase. The provider retained a consulting and billing group. The billing group was the subject of a hack, and the provider, Advocate Healthcare, paid $5.5 million, in part because they never had a sufficiently documented business associate agreement. Next slide, please. If you have a breach, you want to go through the 4-factor analysis that we have here. And again, if you have a breach, you need to be notifying, if you're the business associate, you need to notify the covered entity, and then the covered entity has to report the breach to OCR in the appropriate time frame and must notify affected individuals with 60 days. Again, there are many, many cases where providers fail to promptly notify patients. I have a case that is actually one where they only delayed by 45 days and they got fined significant amounts of money. Next slide, please. One of the things under HIPAA is they have these tiers of fines. I'm not going to go over these in a whole lot of detail, but do know that there are tiers of fines that can apply in your circumstance. And again, HIPAA fines are not insubstantial. Many people think, oh, you know, it's not insubstantial. It's just a minor thing. I've only got 1 or 2 patients that, you know, we lost the records on, or we got a breach, or the email was misdirected. The problem is if you have 1 or 2 and the government comes in and does an audit and sees that you have a pattern of misdirecting, well, then, you know, it just kind of piles on. And now it becomes a pattern and practice. And so your higher tiers apply. One other thing I'm going to put down here is one of the things that OCR is really becoming very insistent upon is that providers have done a security risk analysis. I am shocked by the number of providers that have never done a security risk analysis. And if you have a breach, the OCR will ask for 4 things in their investigation. 1, have you done a security risk analysis? 2, do you have a documented risk management plan? 3, do you have documented policies and procedures on HIPAA privacy and security? And 4, have you been routinely training your employees on HIPAA issues? So HIPAA is becoming a bigger and bigger issue. Next year, OCR is going to restart the audit program that it had. So this is your perfect opportunity. If your HIPAA program, privacy and security program, is not up to snuff, you now have time to get that into place. And again, please do a security risk analysis. If you want resources, please email us. We are happy to provide resources. Next slide, please. Patient abuse or neglect. Again, most states have mandatory reporting laws, and in Texas, the law is anyone with knowledge of suspected or abuse or neglect of a child, an adult with a disability, or an adult over 65 must report to Department of Family and Protective Services. Again, as we put here on the slide, this applies to all individuals and isn't limited to healthcare professional. So if you're a biller, or if you're somebody out, a driver or a scribe or something like that, and you have some suspicions, you are a mandatory reporter. And just remember, HIPAA is not an impediment to reporting abuse or neglect. This reporting does take precedence over privacy limits. And a lot of times people are concerned that if they report, they are going to be subject to some kind of liability. No, you actually do have, generally speaking, civil or criminal liability for making reports if those reports are made in good faith. So again, you really want to be concerned about that. Next slide, please. All right, so this is a final slide, I promise. When you resolve the problem, not because we're attorneys, but you really want to think about hiring legal counsel. Some of these things can absolutely be addressed on your own, but really, if it looks like more than a simple overpayment for a service, you want to think about retaining counsel. First of all, outside counsel can provide attorney-client privilege that may not be available in other circumstances. Counsel can also provide legal strategy, and again, thinking through what knock-on effects or fallout is from a particular issue. If you have potential fraud, you absolutely need to have legal counsel involved, because then you're potentially looking at not just civil but potential criminal liability. And you know, again, attorneys just will help you figure out what you need to do. You also want to be cautious of things like, you know, submitting more information or saying more than you need to. I've had numerous situations where, as Richard said, people get nervous and they just blurt out a whole bunch of stuff, and now you have bigger problems. And the final thing that I'm going to say on hiring legal counsel is, again, this is not a plug for us. This is truly education for you all. Make sure your attorney knows what they're doing. I've had multiple situations where other attorneys involved with the client do not know healthcare. They're my sister's brother-in-law's nephew's cousin, twice removed attorney who did their divorce, and so we retained him. Or, oh yeah, this is the guy who did my simple will and handled traffic tickets for me. I'm going to go to that person for dealing with healthcare issues. Healthcare issues are unusual, can be unusual, and they often involve laws that don't make sense in other contexts, and they have laws that do not apply in other contexts. And so many general practitioners are not necessarily aware of the nuances of healthcare law. So you really want to think through this. And the other thing that I would also say is, again, not a plug for us. You're free to go hire whatever attorney you want, but get involved and retain an attorney before you have a problem. This gives you and the attorney an opportunity to figure out each other's styles and business. It lets the attorney know what your company looks like, and can help you solve potential issues on down the line. When your attorney has to scramble and come up to speed because you have a deadline in 5 days, yes, I've been there, it just makes it very much harder for the attorney to give you effective representation. So talk to an attorney, know who they are, sign an engagement letter with them, you know, just have somebody in your back pocket if things go south. All right, next slide, and I think we are ready. If there's any questions, I apologize for having gone over. Alex, do we have any questions in the chat?
There's no questions listed in the chat.
All right, well, folks, you have our contact information on this slide deck. The slide deck will go out tomorrow?
Yes,
Alex?
it will go out tomorrow.
Yes, it will go out tomorrow.
Yes. All right, so you'll have our contact information. Please feel free to reach out to Richard or me with any more questions or thoughts or concerns that you may have, and we'll turn the rest of your day over to you.
All right, well, that concludes today's webinar. Thank you for joining us, and thank you for our speakers, Heidi Kocher and Richard Pecore. Everyone from today's webinar will receive copies of the presentation tomorrow via email. If you have any further questions about today's discussion or another healthcare law issue, please feel free to reach out to Lyle Parker. Have a good Wednesday and take care.
Bye-bye.